Hello, everybody. Welcome to the conference. I am very sad that we're not meeting in the sunny Southeast, but I hope we can do that in the near future. I'm particularly sad for this session because we were hoping to have a little bit of an exchange, but we're doing the best we can. We've switched to a little bit of more of a formal presentation, and the three of us will have a chance to have our discussion at the end. So I'm Jane Simoni. I'm the moderator for this session from the treatment adherence track, where we're going to be talking about interventions. Then we're going to hear from Dr. Nachega, who is going to continue talking about adherence, especially different community-based approaches, as will Jessica Haberer. And I'll let them present their own presentations as well. Okay, I'll share my slides with you. We're talking about a cycle of evolution and change. So given that, I'm going to step back in time a little bit and talk about 15 years ago, the very first IAPAC sponsored conference in New Jersey. I was there. I proudly say I've been to them all. And during that time, I gave a presentation at the state of the field for adherence interventions. And this was, there were about, in a qualitative study that we did in the turn of the century, really, the field was in a very nascent stage of development. There were only about 21 published studies. Most were pilot feasibilities. There were 4 randomized controlled trials. And we concluded at the time there was really lack of empirical evidence to make many strong recommendations regarding the most efficacious way to improve antiretroviral adherence. A couple years later, the field improved a bit and we were able to do a systematic review and meta-analysis. And at that time, we found about, let's see. All right, you're gonna have to edit this part, Gus, because yeah, you guys are blocking my, I gotta find a way that you're not blocking my slide.
You can pull us up to the top, Jane.
Yeah, I know, I keep trying to do that, and then it's, how many studies does that say? K equals?
19.
19, all right. So I have you guys, all right, I have you up in the very corner now. Okay, so I'm gonna start from this slide, ready? A couple years later, we were able to do this meta-analysis and found there were 19 studies that were randomized controlled trials. Most were conducted in the United States and at primary HIV care clinics. Gay men were the predominant subjects, and most were white. Only a quarter could restrict the sample in any way based on low adherence or undetectable viral load. In terms of interventions, they are mostly done in the clinic by care providers. Sessions range from 1 up to 54 different ones. And the intervention components include information giving, didactic strategies, cognitive strategies, some behavioral, external rewards or cue dosing, or external reminders. And our meta-analytic results at the time showed there was an overall impact. If you were in the intervention, you had about a 50% improvement in adherence compared to the control condition. And in terms of undetectable viral load was significant, but about a 25% improvement over the control condition. And the limitations we cited this time were very few were theory driven, very small samples, limited follow-up, and the measures of adherence usually were limited to either self-report or MEMS only. We didn't have hair samples or dried blood spots at the time. And many lacked the virologic or the immunologic outcomes that we needed. And we said at the time, the genetic economics had talked about the correlates of patient adherence, characteristics of the patient, aspects of the provider, variables related to the treatment regimen or to illness, or contextual and environmental factors. But almost all these interventions really focused on patient characteristics. They didn't look at the full range of interventions that could be done. And this was a huge limitation at the time, we thought. We needed more RCTs, we said, clear hypotheses, and really operationalizing the key outcomes to decrease the chance that we would get spurious results and type 1 errors. We needed more consistent measurement so we could compare across studies, especially when we did analytic samples. And it's okay to report null findings if we get those funded so we find out as well what isn't working. We asked for some more targeted interventions, such as folks using injection drugs, the homeless and pregnant women. And we wanted tailored interventions to better meet these patients' needs. We even thought, to target interventions early on by assessing them and only giving the intervention to those who needed it most. And finally, we wanted more effectiveness studies, not just efficacy, did they work in a research trial, but translating and disseminating them and seeing if they worked in the real world, looking at the cost effectiveness of the interventions. And then finally, something that was actually encouraged by this very conference, better communication and collaboration among the investigators so that we could advance the development of the field. And we, more recently, we wrote an editorial to The Lancet with 2 more issues. There's really low exportability to resource-poor settings for interventions requiring high level of complexity. You saw the one that required 54 sessions. And I think Jessica is going to talk to us a little bit more about this as she looked at some interventions on the African continent. And then the lack of implementation science research. Implementation science methods and theories have come a long way even the last couple decades and have been used in HIV treatment research. And there's more room for that and more need for that to find out where and what the most effective interventions are and where they can be implemented. Okay, I'm going to turn it over next to Dr. Sean Nachega, and he's going to share his slides with you. Again, we're going to hear from him and then Jessica, and then we're going to end with a discussion.
Hi everyone, my name is Sean Nachega. I'm an associate professor at University of Pittsburgh, but I'm based mostly in Cape Town, South Africa. It's a great pleasure to be with you again and with colleagues around here, old colleagues, Jen, Simoni, and Jessica Haberer. So I'm going to focus gonna share my slide. Based intervention, and I focus on how we sustain adherence and viral load in the context of COVID era. So this is a New York Times, just really highlighting how COVID is changing our lives, but also the daily life of our patients. So this has been overwhelming for all of us, our family, but also impact HIV patient, the healthcare system, and how they access their treatment, and actually also how they are able to adhere to treatment, and ultimately how they are virologically suppressed. And as you know, virological suppression, which is the third 90 of UNAIDS target, it's really a key metrics and how we evaluate the impact of intervention, and also our goal of really getting free of HIV is been kind of a challenge with COVID. And I'll try just in a few minutes to convince you how this is happening. So COVID is just adding really a burden, physical, emotional, social well-being on our patients. And this, it adds to its own challenges for HIV, but also non-communicable diseases. And you can go on STI, co-infection, malnutrition, mental health, and substance abuse. And all trigger a myriad of consequences, which has been triggered over the last few months: racism, misogyny, household violence, homelessness, loneliness, depression, and the list just keep growing. So this is really a time to think hard, and we've been doing some great work in terms of evidence-based intervention. And over the last few years, as through differentiated the service delivery model, there was a move to try to get service to our patient from clinic to the community. And this DSD model, which has been promoted mostly in low and middle income country, it's the area I think we can capitalize during this COVID era to try to minimize the impact of COVID. Going back, again, I was so emotional when I saw Jen showing the slide of early meta-analysis that it was really famous, showing really the limitation and how we need to move forward in terms of intervention. To this meta-analysis that I conducted, looking at only community-based intervention, the one that tried to compare community versus clinic-based antiretroviral treatment refill. And so this was an invited paper by Paul Volbering with the current AIDS report. We put and look at all the intervention which try to see for HIV patients who are stable, whether community refilling their medicine at the clinic was different to refill from the community close to their home. And we could show a non-inferiority between those two approaches, which was a good news. And beside that, not only it was non-inferior, it likely also to be most cost-effective and also be more convenient, and definitely the outcome here being virological suppression and also all-cause mortality. So from those interventions, and again, going back, you can notice some key paper from Robert Gross, from myself in Cape Town, and other colleagues. There's been recently even an approach in sub-Saharan Africa to try to look a bit more, collect more data at program level through PEPFAR program, and looking at retention, also impact on viral load. And all this study really supported the success of community-based approach as the way to go. And Jessica going to, in a formal, more comprehensive review, going to come back again on this. This is just big highlights. And again, another advance we've been able to achieve in terms of intervention is as patients are stable, we can space them to have to refill, and instead of monthly, we move from monthly refill to 2 months, and then nowadays it's been even 6-month refill. And there is a well-controlled study showing that comparing 2 months to 6 months refill, there was no harm doing that as far as hard endpoints are concerned. And this is my PhD student, Geoffrey Fati, who, this is a randomized controlled trial in Zimbabwe, outcome of 3 versus 6 month dispensing antiretroviral for stable HIV patient, recently published. And again, he really did confirm that the non-inferiority, looking again at virological suppression as endpoint, just one of the endpoint. But in a more innovative way, from low resource limited setting, but this is a picture from South Africa. You may also be able to refill your medicine in the street like through an ATM machine. Obviously, it does not specify this is an ATM machine for HIV drug to avoid stigma, but all non-chronic disease like HIV, TB, blood pressure, medicine, antiretroviral, you need just to have a code, and you can get like refill your medicine. So in a COVID era, as people stay home, a local entrepreneur who are being able to design it. And this is again one of my postdoc, Rory. We presented data at CROI last year showing also that this is data from South Africa. In private sector, there is the home refill of medicine. So there is a private company which through private insurance, able patient with HIV can have their medicine every 3 months or every 6 months dispensed at their doorstep through, and we did compare doing a marginal structure modeling causal inference, whether what the difference this is making. And definitely when you look at viral load endpoint, it did seem to make a difference. So recently also, all those differentiated service delivery model have been applied in stable patients. A recent Lancet paper by University of Washington, Ron Barnabas, they've been able also to look at patients who are not stable and who are virological breakthrough, and men who are hard to reach. Also, a randomized control trial being able to show evidence that having a community-based approach for that key population, it all in terms of getting them virologically supported. We need also to make significant evidence that SMS, which can still be a two-way SMS, which not just it's not the reminding kind of aspect, but the supporting part of it, which there is a two-way message. People, in the context of COVID, people feel lonely. Having someone who who care for you, who try to check on you, who can counsel you either through SMS or telephone approach. I think in a COVID era, we need to maximize. We just learned that from South African perspective, we are getting out of the lockdown, but some countries in Europe are going back to lockdown. So this COVID has until we have really access to a vaccine, and that may still take until end of next year until this is controlled. So I think we need to start to use all our tool, evidence-based intervention, to try also to see how we can scale up those and to try really to maximize their impact, because we know they work, but we need to put them at scale even more so now with COVID. So I'm stopping there and look forward for more discussion later. Thank you.
So hello, everyone. My name is Jessica Haberer. It's nice to be speaking to you today. It would be much nicer if we were coming off the beach in Miami and sharing this moment together, but we'll do what we can. I'm really pleased to be here with Jane and Jean and talking about adherence interventions. I'm an internist at Massachusetts General Hospital and an associate professor at Harvard Medical School, and have been studying adherence for over a decade now, primarily in sub-Saharan Africa, and focusing on a variety of populations and the use of technology. So I will begin my slides now. Great. So in beginning my presentation, I'm going to pick up on some of the themes that Jane and Jean have already described in this presentation. Just a few of my financial interests, no conflicts. So I'm going to describe a scoping review that I undertook with several colleagues just in the past year, and then bring this more recent information back into perspective to reflect where Jane started us off with her review in 2003. And some of Jean's presentation actually leapfrogged us a little bit because our review doesn't quite go up to the current moment, but try to bring it all together with a few comparisons and thoughts on where we should be going. I think that'll be a nice segue into the discussion that we'll have as a group. So this is the paper I'm going to present to you today. Rebecca Joplin is the first author, and you can see our other colleagues listed there. This was published earlier this year in Current HIV/AIDS Reports. And we focus the review on sub-Saharan Africa only. So a little different than what Jane described, but I think complementary to what Jean referenced earlier. So I think we all know the background here, but I just wanted to review how we came up with the framing of this paper. Because we wanted to focus on what has been published in the Treat All era and really thinking about the 90-90-90 UN AIDS goals. And with adherence, I think over the last 15 years or so, we've been thinking about really what it means beyond just taking pills. And we wanted to combine these two concepts to think about the uptake of ART as one stage of adherence, thinking about the execution of day-to-day adherence as a second stage, and then finally thinking about persistence and how each of these stages really influences the way people are able to take medicine in the modern era. And we conducted a scoping review, and I think it's kind of a hot topic to have a scoping review versus a systematic review or a meta-analysis. And just to put us all on the same page, this review was really meant to say what's out there, what's not out there, and where should we be going as a field. So I'm not going to be quoting odds ratios and p-values, but more giving you a sense as to what's been going on, where some of the evidence is stronger versus not. But I think it's a nice way to think about where we are as a field. And these stages of adherence are going to be overlaid on more of the traditional HIV care cascade. So our methods included a literature review from January of 2014 through to December of 2019. So again, Jean had a few more up-to-date studies, but we got pretty close and finished the review at the end of last year. So these studies were we excluded studies, excuse me, if they were not actually conducted during the Treat All era. Sometimes it can take a few years to get a paper out, so we only included those that had data collected during the modern era. And you can see the databases that we reviewed, the usual PubMed, MBase, Cochrane, and Web of Science. And the way we organized the adherence cascade, as we were calling it, is shown here with 5 steps. And the first step is an uptake of medication. So these are people who have their status known, but have not yet initiated ART. So kind of the early stage of the HIV care cascade. The next 3 steps are for people who are aware of their status. They've started ART, but adherence interventions may be targeting different people. So the first group is really a broad implementation of an adherence intervention for anybody taking ART, not really focusing on one specific group or not. But then the other 2 break it down by suboptimal adherence or people who have known stable adherence. And then the final step is looking at people who have initiated ART but maybe lost at some point. So the adherence interventions are geared towards regaining persistence for those who have lost it. So it's just a general overview of our findings. During that 5-year period, we identified 51 articles, of which about half were randomized controlled trials. Most of them focused on the first step that I described in looking at ART initiation or uptake. Most of the studies were conducted in East and Southern Africa with definite predominance of Uganda and South Africa. And most studies were identifying specific patient populations, which is one area that I think we did evolve into as Jane was recommending from her review. So let's start with the people who have known HIV status or found out their status during the intervention, but hadn't yet taken up ART. So I'm going to present this group, which has by far the most interventions by population, because the studies really did focus differently on these different groups. So in thinking about adults in general, a number of promising approaches were seen. And I think Jean really nicely talked about the evidence base coming out for community-based services for HIV testing, identification of patients in need of ART, and then initiation, often right there in the community, or in facilitating people coming back to the community. And I think our strongest evidence really is in this area. There are a couple other promising approaches as well with really good evidence, but I think this is probably one of our strongest. A number of studies looked at various point of care services, some looking at CD4 counts, others looking at different laboratory tests, but the CD4 counts were most predominant. And then linking those to counseling and facilitating linkage back to the clinic, sometimes with escorted transportation or transportation reimbursement. But various combinations have been tried and generally found to be quite promising. Improved care within facilities has also been useful in helping people initiate ART. That can include elements such as provider education, excuse me, or inclusion of those point of care tests in the facility as well as in the community. And then other interventions have combined all of these strategies, looking at modified counseling, SMS reminders, the point of care, CD4, accelerated movement through the facilities, and also non-cash incentives and co-located services. So it's, I think, really great to see people taking not just one approach, but many and pulling them together. And I think that's been shown to be quite promising in the literature. We haven't seen as strong effects in one study that looked at home visits simply to encourage ART initiation. So I think it's not surprising that the more you can do for people, the stronger the benefit. And then some studies that looked at conditional economic incentives, a weekly SMS, or one study that looked at a trauma coping intervention did not show any benefit. When looking at adolescents and young adults, which is a very challenging population and one certainly where we need more intervention development, the most promising interventions are based on peer delivery of services. The different approaches have been taken, but the ones listed here, I think, are definitely promising. These interventions interlinked community and facility components, often very targeted towards youth, so youth-friendly services. Some involved the use of mobile phones, which are very common and popular among youth, and involving targeted counseling and education, really directed at the developmental stage of the adolescent. When looking at pregnant women and infants, the most promising interventions were able to integrate PMTCT, or prevention of mother-to-child transmission services, with primary care so that women didn't have to get lost right after the birth of the baby. The expert mother model, which I think has been around for some time, was examined in a couple of countries, I believe Malawi and DRC. And the results were mixed, and we're going to come back to why some results were mixed in these different categories a little bit later on. When looking at the female sex worker population, there were also a number of community-based interventions, but the benefits were not as clear as those directed toward the general adult population, and I think really reflect the many challenges that female sex workers face. Another study in Zimbabwe looked at a combination of HIV prevention and HIV treatment, and did see improvement, but it was no different than the control. So I think it's unclear exactly how their intervention was effective. And then looking at a peer delivery of self-HIV testing, the tests I think were used, but the actual impact on uptake of ART was not seen to be effective. And then finally in this category, there was one study looking at ways to increase ART uptake among TB, HIV co-infected patients. And there was some suggestion of improvement, but it was not a controlled trial. So moving into more of an execution of adherence, I'll start by talking about interventions that did not specify a stage or a type of adherence within this group. And these, there are not nearly as many studies in the next several categories I'll go through. But looking at the general adult population, there were a couple of studies looking at SMS reminders alone, and this was a study that looked at a very pragmatic approach, and it did show some benefit at the broad level of doses covered, but it was not a very strong effect. Another study was a randomized trial of SMS reminders linked to real-time adherence monitoring, and that did show improvement, with reminders that were sent on a regular basis to help establish a pattern or a habit of adherence, but not as much with the as-needed reminders for missed doses. There were mixed findings when looking at unconditional cash transfers, and it seemed that those effects were more prominent when addressing people who had the most need as measured by food insecurity. Sorry. There was some modest benefit when looking at peer support groups. And there was one study that looked at culturally appropriate images. It was kind of a social norm study trying to improve adherence through that mechanism, but did not find any benefit. And then when focusing on a pregnant population, there was improved adherence when men were engaged in the PMT-CT services. So when adherence interventions were geared towards individuals with known suboptimal adherence, either through adherence measurement or through viral load, there were several promising approaches that included self-regulation counseling over the phone, an economic strengthening activity, and active visualization of adherence. Other studies looked at ways to improve adherence, which I think is compatible with most country models for intensified adherence counseling in this population. And there were mixed results, but the most improvements were seen as listed here. In one study, they really focused on depression, substance use, and extended duration of sessions as long as they were needed for the individual. And another study kind of took a kitchen sink approach in terms of offering many reinforcement strategies with the counseling, so pill organizers, SMS, home visits, self-help groups, and limiting other medications, which makes a lot of sense. I think that's what we do in clinical practice, and it was good to see the benefit in that study. And then as another approach, again, focusing on execution of adherence, in a couple of studies looking at adherence clubs that were directed either at the general adult population or pregnant women, we saw that there was no difference in standard of care, the adherence clubs versus standard of care, which I think is really an improvement in the sense that there's so much less of a burden on patients, and they really seem to like them. So that was very encouraging to see. And different studies took different approaches of how to conduct these adherence clubs, some being based in the community and some being based in facilities. And one study found that they were actually more effective at the facility level compared to community because of linkages of services and other opportunities at the clinic. But I think, as Jean was saying, we can see lots of benefits for doing this kind of work in the community as well. And then our final group is looking at people who have been on therapy but disengaged for some reason and therefore had losses of persistence in adherence. And looking at the general adult population, one study was looking at better training and supervision of expert patients and staff with best practices and using telephone follow-up to try and re-engage people and improve persistence of adherence, but the effects were fairly marginal. There was more improvement with younger patients, however. And then peer tracing is something I think most clinics do on some level. And one study was able to show some benefit with peer tracing, but only when it was done face-to-face, and that was felt to be inefficient and resource intensive. And finally, there were a couple of studies looking at high-risk groups in this category of adherence. And one study looked at small cash transfers conditional on appointment attendance, and that seemed to be promising among women in the PMT-CT cascade through the 6-week postpartum visit. And those cash transfers were most effective for women who needed the support the most because of poverty. And similarly, another intervention looked at food baskets to improve persistence. And those were most beneficial for people with documented food insecurity, but not necessarily everyone. So I know I've covered a lot of different studies. So just wanted to summarize that we're seeing benefits for ART adherence across many different stages of the care cascade and stages of adherence as they overlay on those different parts of the cascade. So we saw improvements with community outreach and linkage. point of care services, integration of services, different uses of SMS reminders, often in combination with other services. Peer support was particularly helpful among adolescents. Adherence clubs were also very beneficial. The cash or food incentives were most useful when there was demonstrated need. Intensive counseling can work well, depending on how it's implemented, and face-to-face tracing, although again with the caveat on resource utilization. And then some other general caveats for the information I've presented to you today. So most effects were really dependent on context and methodology, and there were no silver bullets out there that would work for everybody with high effects, and I don't think that's surprising. It's always disappointing because you want to see that, but I think context really matters, and it's something that perhaps we can talk about in a few minutes in our discussion. The evidence was of ranging quality. You know, as I mentioned, about half were RCTs, but we included all of the studies that we found in the scoping review, because I think there's a lot to be gained by looking at qualitative studies or looking at, you know, just experience of what's out there to think about where to go next. So it's not that we can only learn from RCTs, but we do have to keep that level of quality in mind as we interpret the data. And I definitely recommend reading the paper in more detail to see exactly where that all falls out. As Jane mentioned in her review, there are definitely some gaps to consider in the methodology out there. Many studies were very non-specific and referred to counseling, which I think we know, you know, one counseling session does not equal another. The use of theory was spotty at best, and a number of studies, including objective adherence measurements, were relatively low. There were some studies with MEMS caps or other types of electronic monitoring. We definitely saw more in the way of dry blood spots and certainly use of viral load compared to the review that Jane presented. But I can't say that it was in all of the studies or most of them. And then the final aspect of the literature that we reviewed was looking at ongoing and future work based on published protocols, which I think have become much more common in the last several years. And most of this research is really oriented in the community. Again, as Jean mentioned, this is really, I think, where there's a lot of exciting work going on, looking at community workers and peers and focusing on high-risk populations. There's a study going on with men, with youth, and there's another with fisher folk in Uganda. Some studies are targeting comorbid mental health disorders, specifically depression. I think that'll be interesting to see how people are looking at in the modern era, especially in light of things like COVID. And then more work going on with the community-based differentiated care delivery, in particular, thinking about adherence clubs and other ways to make services work the best for people in their home communities. So just to go back, I know I've been referencing back to Jane's presentation, but just to refresh our memories, you know, our study had 51 in the last 5 years, hers had 21. I think the categories are quite different in terms of where interventions have been focusing. You can see the categories listed there from Jane's. The number of RCTs, again, is relatively low, but I think we had a higher proportion in quite different areas compared to where the literature was 15 years ago, or 17 years ago, I guess. And I liked in Jane's paper how they were calling for a superior methodology and sophistication and innovation. And I feel like we get a plus minus on that in the last 15 years. I think we've moved beyond pagers and alarms, but and have definitely increased use of technology, sometimes showing benefits, sometimes not. But that role of social and emotional support, I think, is there. I don't know if we've been studying it in a targeted way, but I think that may be part of what's going on with some of the community delivery. So in summary, I feel that there's a lot going on. A lot has been done. And I do feel like we are getting more sophisticated in the way we're thinking about adherence beyond just pill taking. And I hope our scoping review showed how we operationalize that by thinking about what is needed when and why. how there are really important differences among different populations and why one intervention or type of intervention may work in one setting but not another. And I think as we go forward and use more of those implementation science methods that Jane mentioned, I think we're really going to need to focus in on that so we have a sense as to when something that looks promising in one population can be translated to another, and what we might need to do to make that happen. And I think a lot of the recognition of structural barriers to adherence has been really helpful and underlies a lot of the benefit we've been seeing with community delivery. And I think I won't reemphasize this point too much about the areas where we're still struggling in terms of rigor, but I was surprised at the limited number of studies with no theoretical basis or use of objective adherence measures. And I think finally, with another area that we could hopefully improve upon in the next 10 or 15 years, I'm not sure when we're going to take another look back at adherence interventions like this, but I think, based on some of the limitations in funding and other ways of doing research, we often look at a narrow aspect of adherence, and it's really such a broader issue. And we can try to improve what's available to us by focusing on uptake, execution of adherence, or persistence, or one aspect of the care cascade. But these are comprehensive problems, and I think we really need to challenge ourselves to think about how we can work together and really encompass the comprehensive nature that's really inherent in adherence to therapy. So I think we're moving in the right direction with recognizing the complexity and nuance of adherence, effective adherence support. And I'll also add one other point that maybe we can talk about in the discussion, which is an issue of relevancy. And those of us who are attending this conference, I think, are in the choir. I think we all really recognize the importance of adherence and ongoing importance of adherence, even as many settings are reaching those 90-90 targets, or even 95-95-95. But some people don't agree with that, and they feel that adherence is really a solved problem. But when you look at even the basic math of people meeting the 90-90-90, that's nearly 30% of people who are not suppressed. And we haven't even talked about durability of suppression and how many people fall out of care over the lifetime of necessary therapy. So I think there is a great deal of relevancy, but it's something that we should consider as how best to position ourselves in the field. And then in terms of other areas to consider, I think the focusing on populations at high risk is really important. Thinking about how health systems really impact the delivery and how that's changing as we're looking at treatment of non-communicable diseases in many of the settings I've described today, how to integrate that and really maximize our impact. I think another really exciting area is looking at new formulations, and we have some great data coming out about injectables, which I think can be incredibly helpful for adherence, but they may come with their own challenges, such as returning on time for that injection, or creating health systems that can manage the supply chains or the proper staffing to give injections. So I think there's a lot of research that can be done in that area. And of course, continued attention to the key role of mental health, which is so important to adherence. So I hope I haven't talked too long, but thank you very much for your attention, and I look forward to our discussion.
Thank you very much, both of you. Those were two excellent presentations, really from two titans in the field of adherence research globally. And I think they did a great job of showing how far we've come in 15 years, but yet also there's room to go further and to improve the field. I just want to make one comment, and then I'd like to open it up with two questions that you can answer, and then add anything else, of course, that you want to say. But my one comment is something that Jessica alluded to a couple times too, and that is just like in prevention science of HIV, we've moved combination strategies. I wonder if it's time to talk more openly and comprehensively about combination adherence treatment to treatment approaches. And I'll give you some examples. So if we're doing a little work in Haiti where we looked at multi-month scripting. So instead of requesting patients to come in every couple of weeks or a month for their meds, maybe come in every 2 months or just every month or every 3 or maybe even 6 months. So that should be a great reduction in the burden of coming to clinic. And some of the data, early data show it can be helpful, not as helpful actually as we thought it was going to be. So we see that just coming to the clinic, although it was one burden, doesn't completely alleviate the stressors of taking daily medication or daily pill taking, for example. So our next steps there are thinking, well, we'll have multi-month scripting, but now we need to increase the capacity of the community mental health workers or health workers to go out and assist people. Maybe they deliver the medications, but they need to go back in between and talk about how people are doing with the medication. So really a focus on combination strategies that are needed. And I think these might be more successful. And they're particularly important. In this example, we talked about long-acting strategies. So I don't think it's going to be a panacea that, oh, you get a shot once every 3 months, now everyone's going to be perfect. You still have to go back and get your shot. And even if we do have these multi-month scripting programs, we still are going to need help on a daily basis or dealing with adherence on a daily basis and sustaining them. So that's just my one comment, that we might need to think about more comprehensive packages as we think about adherence interventions. And then I want some for my question. It's a double-barreled question. The first, this adherence, we like to think about trainees and how they're doing and provide opportunities for people entering the field or starting their practice in terms of adherence. So one is for the budding researchers in the group. Maybe they're thinking about doing a K award. They're very interested in treatment and treatment adherence. You are two experts in the field, have done very well in your respective careers. What guidance do you have for them? What are some areas they might go into as a junior investigator? What is something that they can look at that will be significant and innovative? And the second part of that question is, what about the clinicians? Most of the attendees are clinicians at the conference. Some of them are starting up their career in places with very few resources. What advice do you have for them? They don't have time to go back over the last 15 years of results from this conference and find out what they need to do. What can we tell them? How can we guide them when they go back, next week to their practices? What can they do? What can they take away that will improve what they're doing? Are there evidence-based approaches, or are there ways that we can recommend that they get access to evidence-based approaches to assist them? So that one comment, and then just the two questions about how to guide new researchers and new clinicians as a way to start things off.
So maybe I'll go first, if that's all right, since you're on mute. So, for your first comment about combination, I think absolutely, there will be no silver bullets, as I mentioned, and I think we need to consider, the individual barriers, the structural barriers, everything that people are coming up against. I think one of the challenges, though, as a researcher, is how do you pull all that together in one study, and it is really quite challenging to do. With limited budgets and that sort of thing. But I think it's an area that we need to be innovative in and think about different designs and different models that may allow us to be a little more nimble than we have been, and perhaps thinking beyond just the standard RCT. So with trainees, I think some of the really hot areas are, as I kept saying, within community delivery. I think that's going to be continue to be so critical, and seeing like the DuArt study that you mentioned, Jean, there's just really a lot of excitement there, and perhaps combining that with the injectables or some of the newer approaches that are out there, I think would be really informative, and thinking about ways of delivering therapy, like if you said, Jean, and with COVID in mind, because I think sadly we're going to be stuck with this situation for quite some time, and hopefully it'll go away, but we don't know what's going to come back. So having nimble designs for our studies, but also nimble interventions, and thinking about health and the way that can play into adherence interventions. And I always consider myself an optimistic skeptic or a skeptic optimist about health, because I think it can do a lot, but I think there are real limitations to it. And I think there's a lot for young people to think about. You know, what is working, what isn't working, how is it working, using implementation science to explore that. So there are lots of, I think, really interesting areas for people to pursue. The challenge in doing that with an epidemic like HIV is it is so global, and travel is almost impossible these days. So that certainly is something to consider. But those are the main areas that I would recommend. And sorry, remind me your second question.
Or clinicians. What about clinicians?
Yes, what's going to work for clinicians? That's so hard. I'm a clinician myself, and you know, often in clinical practice, you know, it's just you in the room, and it's so hard to implement new interventions that require like changing of a healthcare system, or the types of counseling that you're able to provide. And I'm an internist, I'm not a psychologist, but thinking about the messages that I provide to my patients. So I think, you know, looking at your own individual setting and looking at that list, you know, that I went through, and that all of us talked about things that may work. But think about your context. Think about what is changeable for you. Like if you can redesign how often people come in, or what types of services they have ready access to, look and see what makes the most sense. Because I think there's a lot out there that can help people. And as some of the interventions I covered, you know, they use a variety of approaches. You know, I referred to the kitchen sink at one point, and you know, sometimes you need to do that because everybody needs something just a little bit different. And one of the nice things about the literature review is to see that there are many options. You know, it may be that a different type of counseling, or a different type of outreach, or a different way of structuring the clinic can make a difference. And so I think, you know, looking at your individual populations, you know your patients, you know what the environment is like, see what's feasible, what looks like it's going to have the most benefit, and then try it out, and work with your patients to see what's really going to resonate with them, and help them when, where, and how they need it.
Great, thank you. And I wonder if you had any comments for researchers and clinicians.
Thank you very much. I think I'm going to speak with a perspective in LMIC, and I'm glad to hear you work, Jen, in Haiti. I didn't know that, so I'm excited to learn that. I think there is two areas I will recommend. I am a PI of a D43 on HIV comorbidity. And this is an area we did not discuss as people are aging, HIV people, our patients are aging. So comorbidity, cardiovascular, chronic kidney disease, and so on are becoming, like in the US, in Europe, in Africa perspective also, it's something we need to start to look at it. And I think it's a good area for or build a career, and we training a young, bright investigator with NIH Fogarty funding. So that's one area I would recommend. And another area which I will recommend, which have some promising career opportunity, as Jessica mentioned, there is some exciting work coming out about key population. So it's an area that we still have a lot of work to do. We mentioned about men hard to reach, but commercial sex work, MSM in Africa, it's kind of a new area. I know Cape Town is well known for good work on MSM, but in other African countries, it's quite difficult to conduct research on MSM. Stefan Barral at Hopkins is in key population, investing in that area. So I think this is a area we recommend a young investigator to engage in. You know, pregnant women also, but that's body of work is growing also in that area. Yeah, so those are the two spots I will recommend. But Jane and Jessica, I would like to come back to the earlier discussion about you know, combining interventions. And I agree with you. Something I think I've been quite learning, working with people like Elvin Gang and and the folks like Ed Mills, is all the idea of the new exciting study design with adaptive study design, with the concept that you know, one size does not fit all, and not everyone need intensive intervention at first. It's going to depend, as we say, you know, some people, obviously people combine individual structure, behavioral barrier, but at different level of intensity, and you may need to tailor your intensity of intervention depend on for what issue you need to address. So that, I think it's something that I'm getting to learn as we designing also intervention that using the adaptive study design, which step up from just baseline counseling to MSM and even intense like home visit, where you can, and whether you can combine some of those. So those of area also, Elvin Gang, and is doing some exciting work on it. Yeah, so I'm not sure if you have any comment about what I just said.
Sure. Yeah, I completely agree. You know, as I was saying, I think we need to look at innovative designs in order to really capture how adherence is supported in real life. You know, as a clinician, I don't just give people option of A or B. You know, it's A and then B, and if B doesn't work, then A plus B or maybe C. But these are challenging designs to really carry out. And
I agree.
But you know, I think we can rise to the challenge and we can figure this out. And I think it's really reflective of life, and that'll get us closer to actually understanding the science and how, you know, Jane, you were saying we need more effectiveness studies and not just, you know, efficacy. So absolutely, I think that's the way to go.
Yeah, great points. I think we're nearing the end of our time if we haven't completed it yet. But I wanted to thank you both. This is an excellent presentation, and we'll end with that message really, that we've come a long way in the 15 years of this conference, but in this cycle of evolution and change, there are still exciting, important directions we need to go. I remember I wrote my first grant, I think in 1997, there was a call for adherence interventions, and I said, I better hurry up and get mine in, because this is the first call and we're doing them. So those of you looking for your K award, it's still, the program announcement, I think, is still out there. We still need adherence interventions. We need people from diverse backgrounds and experiences with clinical experience who can really help to provide ideas that are really relevant or feasible in clinic settings across the globe. So I want to end with that, a plea to our young investigators to persevere, connect with us. I know the three of us here are active mentors. Those, we can't be at the conference, we don't have a chance to talk with you, but please do, even in this virtual contact and conference, reach out to us and I encourage you, and those on the front lines as well, especially in the era of COVID. Thank you for all the work you're doing. I thank my presenters, and I thank IAPAC for the opportunity to speak with you today.